When Koki and Jeff invited me to speak at this conference a few months ago, I was very honored, but when they said I would speak at the last session and probably be the last speaker in that session, I thought that I envisioned an empty room, and I was wrong, which is great. Thank you for the invitation. So, today I'm going to reflect with you on some of the big trends in the field of maternal health and about some countries from which we can draw lessons that will hopefully help us move the field forward. Some general statements that you are all familiar with. We are now seeing global and regional trends that definitely show a decline in maternal mortality. The sources are different and the uncertainty intervals are quite broad, but the trend is undeniable. We have now better sources of data, and we have also better techniques to analyze those data. Interestingly enough, we are reaching a big consensus about the specific interventions that work, and now 56 packages of interventions have been already accepted as the ones that are more safe and effective. The skilled attendance at delivery is on the rise, and as the 2015 deadline approaches, countries are increasing their efforts to reach the goal. So what can we learn from countries that have made especially good progress? Let me show you some cases. Some of the numbers may differ from the numbers you have, and that's because we may be using different sources. In my case, I'm using the Institute of Health Metrics and Evaluation as the source of these numbers. Anyway, the numbers are pretty uncertain, but the realities are still very, very valid. So briefly, Egypt. Egypt is a country that went from a relatively high to a low maternal mortality ratio. In fact, MMR dropped by 52% between 1992 and 2000. They worked on both the supply and the demand side at the same time. They did extensive training, revised curricula, improved equipment, drugs, supplies, medical protocols, upgraded medical facilities, and at the same time they worked very actively with the community, delivering media messages and campaigns and implementing community outreach programs. Iran is another success story. Iran went from a relatively low to an even lower maternal mortality rate. Something pretty unique about Iran is their family planning program that achieved incredible results. In fact, the total fertility rate went from 7 children per woman in 1986 to 1.96 replacement level recently. And at the same time, they also implemented activities directly focused on improving maternal health. They put in place a very ambitious rural midwives program supported by a very strong referral system. At the same time, they also work with the community, particularly with religious leaders that they managed to involve in their efforts, and also with public education campaigns. Two other examples, Malaysia and Sri Lanka. These are two countries that started their efforts to improve maternal health well before the Safe Motherhood Initiative was launched in 1987. In fact, they've been fighting really hard to improve maternal health for many, many years. In the case of Malaysia, they established a very ambitious midwives program, professional midwives program, that do a wide range of things, and I don't need to tell many of you in the room about that, but anyway, just summarizing: home visits, attending deliveries, making referrals, carrying out maternal death reviews, and many more things. Also, the services are free, and the referral system is really strong. In the case of Sri Lanka, the effort started in 1950, and a health infrastructure, a very strong one, was established at the time. Services are also free, family planning also integrated, a referral system functional as well, and a strong health information system with a good civil registration and maternal death reviews. the case of Bangladesh, I don't need to tell you anything about Bangladesh. I think it's been fully covered during the conference. What I can say, though, is that Bangladesh is making important progress. In fact, women are now 53% less likely to die during pregnancy and childbirth compared to 1980. So, what we know works from a very high-level perspective: strong and sustained political commitment to maternal health. We also know that an improved infrastructure is mandatory. We also know that improved or acceptable quality of care is absolutely essential, and that we need functional referral systems. It's also important to ensure access at the same time that quality is improved. It's also important to integrate maternal health with other reproductive health services. The community needs to be involved through culturally sensitive and appropriate mechanisms, and we need strong data and evidence for decision-making and prioritization. In spite of the successes that I just mentioned, many challenges remain. And we can also learn from countries that are struggling now with some of the big issues. So let me briefly mention three of them, one of them not from this region, Ethiopia. Ethiopia has engaged in the last few years in a very, very ambitious program. They've trained 30,000 health extension workers. They've established 14,000 health posts, and they are deeply involved in improving maternal health through their health sector development program. But despite these efforts, their maternal mortality rates have not declined. And in fact, they were quite disappointed when the last DHS showed that there hadn't been any change in the last 5 years. So the most likely explanation is that in spite of having increased access to delivery, to institutional delivery or to skilled care, I should say, the quality of that care is still far from where it should be. So now they are working really hard to improve quality. In the case of India, another country I don't need to get into any detail about here, well, as you all know, the JSY program is the largest conditional cash transfer program in the world in terms of the number of beneficiaries, and it has increased so significantly the number of institutional deliveries. In spite of that, maternal mortality that has declined still remains too high. The most likely explanation in this case is that the increased workloads for health personnel have had an impact on the quality of care that probably wasn't ideal to start with, and now it's becoming even more challenging. Well, I don't know what the... Oh, it's gone. So finally, my last country case example, the Dominican Republic, a small island in the Caribbean you may not be very familiar with. The Dominican Republic, in the Dominican Republic, more than 95% of women deliver in large hospitals, but still their maternal mortality is quite high. And that's basically due because the quality of care is so poor there. Normal deliveries are treated in a very, very over-medicalized way. Complicated deliveries are not managed appropriately or timely. Providers suffer from compassion fatigue and are demoralized and overworked. And the result is that their maternal health is still very, very poor. So if you ask me what we think limits progress, one of the main reasons is that access and availability of services are not enough to improve maternal health. And quality of care, from my perspective, and I'm very pleased to see that that seems to be a consensus in the room because it's been mentioned so many times during the conference, quality of care, improving quality of care is the most important challenge that we need to tackle in order to reduce maternal mortality. Sorry. The Maternal Health Task Force is a project that we manage at the Harvard School of Public Health that is generously supported by the Bill and Melinda Gates Foundation and by the MacArthur Foundation. And the Maternal Health Task Force has identified the improvement of the quality of maternal health care as its main area of work. Among the many things that need to be done to improve quality, we decided to focus our efforts on the improvement of providers' behaviors, both technical and interpersonal. Our second area of focus is measurement of quality of care. That is also a big gap that we as a community need to fill. We are working in 3 priority countries, India, Nigeria, and Ethiopia, but we are also planning to work in other countries in collaboration with an organization in Bangladesh here, ICDDRB, so that will allow us to expand our geographic focus. And we have a strong educational component too, that is also focused on improving quality of care. So very quickly, those are our 4 areas of focus that I just mentioned. And in fact, I would like to close this presentation with this statement by one of the most outstanding champions in the field of maternal health, Mahmoud Fatala, that said many years ago, the question should not be why do women not accept the service that we offer, but why we do not offer a service that women will accept. Thank you very much.